This is, can you hear me okay? This is session PM2, improving transitions here in the library at the Royal York Hotel. So if you're in the wrong room, you can exit now. This is the session you want to be in. My name is Dan Kaniak. I'm Senior Vice President with Revera, and I'd like to welcome you to the session this afternoon. We are going to have our panelists present one right after the other. We'll have a 20-minute Q&A session at the end of the presentation. So I'd ask you to hold your questions until then. But we'd like to get started on time, as I know that people are anxious to get to subsequent sessions after this. So let me just introduce for you our panelists this afternoon. Colleen Sri Ram is a doctoral student. For the past 10 years, Colleen has spent time in clinical practice as a registered nurse, and of those years, 6 years were spent as an advanced practice nurse specializing in geriatrics and wound management. Colleen has a master's degree in nursing from the University of Toronto and is currently a doctoral student at the Institute of Health Policy and Management and Evaluation at the U of T, Health Economics. Colleen's primary research focuses on the delivery of health services to seniors in the home and community setting and the impact that it has on other sectors of care. Dr. Susan Bronskill joined ICES as a scientist in June of 2002. Her cross appointments include assistant professor in Department of Health Policy, Management and Evaluation at the University of Toronto, and associate scientist in the Clinical Epidemiology and Health Sciences Services Research Program at Sunnybrook Health Sciences Center. Dr. Bronskill received her doctorate in health policy from Harvard. Her BSc in economics and master's in health administration are from the University of Toronto. Matt Snyder is with Behavioral Supports Ontario. Matt leads a team planning, managing and evaluating Behavioral Supports Ontario. BSO is, of course, a collaboration that unites hundreds of partner organizations from the long-term care, acute, primary care, and community services sectors to transform client care for people with age-related dementia. In previous assignments at the Ministry of Health and Long-Term Care, Matt developed the Emergency Department Pay for Results program and a basket of resources to reduce hospital admissions that later became Health Quality Ontario's Best Path Care Quality Initiative. Matt is completing Lean Six Sigma training, the emerging standard for care integration and quality improvement projects. Christine Romanek is from the Erie St. Clair Community Care Access Center. Christine is an RN, a BSCN, and has worked in health care for 35 years, progressively owning both her education and experience. She is presently employed with the Erie St. Clair CCAC Windsor branch. Her present position is Behavioral Support Ontario Care Coordinator for ALC hospital patients in the Windsor, Essex County. She has participated in a tremendous amount of educational opportunities to increase her expertise as PISAs, GPA, conflict resolution, Montessori methods for dementia, to name but a few. She has held this position since its inception and has been involved in developing the resources and community collaborations required for its success. To this position, Christine brought 8 years of case management practice, as well as a background of organizational and community involvement that involved board work, health education, and fundraising. In addition to case management at CCAC, Christine's organizational and systems experience has included a variety of roles on committees dealing with amalgamation, technology, and restructuring. Prior to joining the CCAC, Christine's experience includes hospital positions in oncology, ICU, CCU, ER, and NICU, and I'm glad that everyone understands all those acronyms. I think I got 2 or 3 of them. The area of psychiatry has always been an interest. And there's another panelist that I don't have a bio for, but Mary Ellen Parker is here from the Alzheimer's Society as well. So thank you very much, and I would ask Colleen to please step forward. Thank you.
Okay, so the title of my presentation slightly changed from what's in the program, as well as my research has recently changed as well after speaking with Dr. Samir Sinha. We're including an additional section to my research, which I'll be presenting today. So, to address the needs of the aging population and reduction of wait times, the acute care services, the Ministry of Health committed $1.1 billion over 4 years for the Aging at Home strategy with continued investments to improve home and community care services. The Aging at Home strategy focused on shifting care that is provided from the hospital to the home and community sector, with focus on minimizing deterioration of health and promoting independence with the community supports. In response to the ministry's priorities, the 14 LHINs distributed funds to support the needs of seniors in the community. One of the programs developed was the Home First program, delivered through the CCAC, and across the different LHINs, Home First is delivered differently to meet the unique needs of the community. So the design of the Home First program is essentially a method to get seniors discharged from the hospital and back home where they can have more time to make decisions about alternative care settings or consider options to better support their care needs. The Wait at Home and Wait at Home Enhanced programs are designed to provide extensive services for complex high-needs seniors for a maximum amount of days or per hours, and varies between the two groups, while the Stay at Home program is designed to provide services to help the clients remain independent as long as possible in their own home. So, where are most of our seniors residing? So, previous work from Dr. Bronskill through ISIS's analysis indicates that the greatest percentage of change by seniors by LHIN is Central West and Mississauga-Halton. So we can see a percentage of seniors in Mississauga-Halton LHIN has increased significantly in comparison to the other LHINs, above 25% over the past 7 to 8 years. Therefore, looking for strategies to better manage seniors' care and in the hospital and home and community sectors becomes a priority to improve the overall delivery of care, to reduce costs and increase cost efficiencies. Despite the increase in seniors' growth in Mississauga-Halton, they still have the lowest percent of individuals occupying an ALC bed compared to the Ontario average of 16%. ISIS's data also shows us that the lowest percent of unscheduled emergency visits is also found in Mississauga-Halton. Based on the data, we have seen, or we are questioning what keeps seniors out of emergency departments for unscheduled or non-urgent issues, and what factors are associated with reducing ALC bed days and long-term care placements. Mississauga-Halton was chosen to complete this analysis as they were the pioneers of the Home First program, and they have one of the lowest ALC and ED visits and long-term care placements. And we wanted to investigate to see what services and elements of care delivered are a result of these reductions. So the purpose of the study is to investigate what services and programs delivered through Mississauga-Halton directly and indirectly impact seniors in the community to remain at home. The study has recently included a component where we plan to investigate the impact of supports of daily living and how that impacts the reduction of seniors' use of ED and hospitalization for non-urgent needs, and how that could be better treated in the community. For SDLs, so supports of daily living, there are several programs, so we decided to narrow them down and exclude community support services. So we're going to conduct a comprehensive assessment of the costs and quality of care associated with Mississauga-Halton's Home First program and the supports of daily living at a system and individual level. We're going to investigate how Home First and supports of daily living helps to reduce ED, ALC, and hospital admission with support and integrative delivery models, so homemaking services, PSW support, etc. We're going to determine the socio-demographics and clinical characteristics of individuals who receive those services, and we're going to determine the impact that the Home First program and the supports of daily living has had on care recipients' quality of life by using the RIE tool. So there are several research questions, but the main ones are, we're going to, the first question, we're going to assess resource expenditures associated with the Home First program and supports of daily living. We're going to do system costs, which will be defined in this evaluation as health services that are publicly financed or subsidized through the LHIN. Program costs will be determined as costs incurred by CCAC or Mississauga Halton LHIN. The distribution of services for the second one will include the quantity of services delivered to clients, so nursing services, professional services, and non-professional services, including homemaking. And determinants will include demographics, so sex, marital status, etc., clinical characteristics of each care recipient. So this question will assess the impact it's had on other sectors of care and wait times. For quality of life, we're also going to use the RIE tool at 2 different intervals to assess quality of life as experienced by the family and patient. So the methodology, I won't get too much into it, but we're going to do a regression model for the costing. We're going to use a multivariate regression analysis to determine the extent to which each independent variable determined by the health system and program costs at 3 intervals, so 30-day prior to receiving services, during, and after. This analysis will adapt the Anderson and Newman conceptual framework to help determine appropriate variables such as demographics, family resources, and perceived needs. And then I'm going to do a difference in difference technique, which will be used to assess the incremental impact of health service usage prior to receiving services, and then after between the 2 programs. We're going to use retrospective data from 2007 to 2012, and this will examine the differences in health service usage for those who receive the programs. To investigate the differences between patients who receive services through the Home First and supports of daily living, we're going to do propensity-based matching between the 2 groups. Program impact on other sectors, we're going to take individuals' OHIP numbers for each program, and we're going to track their health service utilization to look at ED usage, hospitalization rates, family doctor visits, medication use, etc. And then again, we're going to use the RIE tool, which is a multidimensional scale to assess a person's quality of life. So just looking at some preliminary data that we got from the LHIN, we wanted to look at Home First profile. So if you look at the RIE score, about 76% of clients in the Home First program have a RIE score greater than 15, which indicates high level of care needs. And then with the SDL, which again we took from the LHIN, you can look at the MAPLE score, which has a 73% of clients with moderate to high needs. So if you look at this, this is a good indication that patients with complex care needs can be managed well in the community. So I think this is a really interesting slide because it provides data that from Mississauga Halton CCAC on the disposition of Home First clients. And if you take a look, about 24% of the clients on the Home First program were discharged to long-term care. Now, if you remember from the first few slides that we discussed, the Home First program, 2 of those programs were focused on getting seniors out of hospital from an ALC bed into the home and community, where they have an opportunity to make a decision about alternative care needs. So if you look at this, the 24% may result from seniors choosing long-term care as their care needs, as they felt they couldn't be supported within the home and community. But a previous study by Dr. Paul Williams and his colleagues looked at patients who were on a long-term care wait list and had an expert panel assess patients waiting for long-term care, and the panel came to a conclusion that majority of the patients, I think except for 2, were able to be supported safely in the home and community with supports of daily living. So this is just a graph that, again, I took from the Ministry of Health, Mississauga, Halton, Lynn, and it just shows that approximately when Home First started and the Supports of Daily Living was initiated, you could see a reduction in ALC and long-term care placements, which could be correlated to the start of these programs. And then again, I took this from Narendra Shah, if I said that right, a 30-day hospital readmission rate. So if you look again, Mississauga Halton again is one of the lowest on this graph. So it shows that they're doing an excellent job. So we're trying to relate what is it that this Lynn is doing different to reduce their readmission rates. So in conclusion, so our preliminary data suggests that there's a correlation between the Home First program and the Supports of Daily Living program to reduce ALC, long-term care placements, and readmission rates. Understanding key elements of both programs is important to understanding where healthcare dollars can be spent and help in reorganizing the delivery of care. And policy and decision makers need to ensure that care is distributed based on needs, so those that are most vulnerable have access to these services. We need to explore aspects of seniors' social capital in their community as well, as this impacts the individual's ability to live independently as possible in their community. And we need to look at shifting care models where both CCAC and Supports of Daily Living program can work with an integrative care approach. So those in CCAC who identify patients for long-term care are assessed by Supports of Daily Living to ensure that institutionalization is the last alternative. Understanding these key elements is key in providing the most cost-effective care and delivering the right care in the right care setting. That's it. Questions now or later? Okay.
That was really interesting that Colleen happened to share some of our graphs from earlier work that we've been doing related to older adults. It's a nice little promotion midway through the session. I'm going to talk to you today about a specific group of patients, so those who are ALC and the transitions that they undergo in the health system. But this is part of a larger body of work that we've been working on at ISIS, which is looking at special cohorts and how we start to track them across sectors. So for those of you who've done health services research or worked with the big administrative databases, a lot of the work to date has been single sector. So what can we say about hospitalized patients? What can we say about home care patients? But I think it's really interesting to start looking across the sectors as we look at where the best place for people in the system might be. But then from a research perspective, this poses challenges in terms of how you measure those kinds of transitions, how you look at the time windows between different settings and things like that. And so I'm hoping with this audience, as I show you things, if something doesn't jive with you or doesn't make sense from your more practical perspective, feel free to stick up your hand and say, I think you should be considering this factor. And so I hope this can be a bit of a conversation. I'll show you some hard data, but I'd like to know what additional information you might need as we move forward with these different groups that we look at. My co-author, Nadia Gunraj, is in the front row as well, so if the questions get too hard, I'm just going to pass them over to her. And this is actually work that came out of a request from the Ministry of Health, which was for people who were ALC, what kind of contact did they have with the system beforehand? So I think there was a bit of a myth that some of these folks were unknown to the system, and so really a sense of, is it possible to intervene? If you were going to try and intervene before someone became ALC, what setting, where might that be? And so this was just some initial descriptive work to look at that, and each of the slides that I show you, we can probably drill down in a fair bit of detail. So we're going to talk a little bit about kind of broadly thinking about how to profile cohorts with increased vulnerability as they move through the health system, so which transitions are important to capture and what other groups we should think about studying. For those of you who don't know about the Institute for Clinical Evaluative Sciences, we're an independent nonprofit organization that gets core funding from the Ministry of Health, although our research outputs are at arm's length, so independent scientific research. And we look to support health policy development and guide changes in the healthcare system. So we have access to the large linked administrative database holdings for the province, so reflecting roughly 13 million of 33 million Canadians. And then increasingly, our databases are not including just administrative sources of information, but also they're being linked to population health surveys, and individual ISIS scientists may bring in primary data depending on their research question or area of interest. We're a prescribed entity under provincial privacy legislation, which allows us to have the data linked at the individual level and conduct analyses, although none of us can obviously access individual level patient information, and this is all sort of strictly controlled. So we're able to follow patient populations through the health system, and we're able to produce population-based estimates. So within your LIN or within your CCAC, you may have a lot of rich data about your organization or group. And I think what we're hoping to do with some of this service work at ISIS is to be able to replicate some of those kinds of standard reports or standard measures over time and across conditions and across different regional settings. So there's been a lot of policy discussion around alternate level of care days and where seniors should receive their care. Colleen's presentation looking at right care, right place. And so they've just in the past year or so alone, there have been a number of different reports. We're all looking forward to Dr. Sinha's report, seeing the full report coming out in the next few weeks, hopefully. And at ISIS, too, as part of a contract we've had with the Ministry of Health, we've been looking at reporting on older adults as they move through the health system. So we did a chart book in 2010. We did a more comprehensive report looking at 4 cohorts in 2011. And really, this idea of frail seniors keeps coming up. And even though the majority of older adults will not be burdened with a significant number of chronic conditions as they age, there are important concerns related to those who have particularly heavy needs and where they're receiving their care. And there are lots of challenges in terms of being able to predict or identify these individuals at the population level, whether you're looking at their clinical comorbidities, their cognitive and functional abilities, their levels of frailty, their levels of system resource use. And there are challenges in providing care to these populations just based on the fact that they've got an increased number of coexisting conditions. They have a contact with many different healthcare providers, and continuity becomes a challenge. And then also there are often needs that need to get addressed beyond healthcare. So whether you're thinking about things in the social or community services spectrum. So this was just a small, as I said, it was a small little project that came from a question by Peter Biasucci at the Ministry of Health, which really, he was hoping for an enhanced understanding of ALC patients as they move through the healthcare system. And so we looked to see among a cohort of individuals who had ALC stay as part of their hospital stay, we wanted to look at their contact with the system prior to the ALC episode. Either were they known to the system or unknown? And then we've also looked a little bit to see in a very short time window, so just 2 weeks, where people were going after they were discharged. There's lots of literature on profiling ALC patients in Canada and in Ontario. Just highlight work by the Canadian Institute for Health Information from Andrew Costa and John Hurdes at the University of Waterloo. And obviously the Walker Report had some recommendations for Ontario in terms of community investments and improving patient flow. So what we did, and I'll describe it in research terms, and then for those of you that aren't researchers, I'll show you some nice pictures so that you get a sense of what we did with the data. But we built a retrospective population-based cohort study. So we identified roughly 35,000 patients who were 65 years of age and older and were discharged alive. There would be people who had hospital stays and who had ALC stays who might have died in hospital. We weren't focused on those people. We wanted that discharge date because we wanted to be able to see where people were going. So we identified these people in the hospital, linked administrative data sources, the CAI-HIDAD, and then we linked these data to other health system data. So home care data, emergency department use, physician services, drug therapies, some limited demographic information. We looked at long-term care admissions and other inpatient admissions. And then what we did is we looked back 1 year from the date people were admitted to hospital to describe the health system's services that they used in that time period. And then we looked one day, and this is one place where we need a little bit of input in terms of how we think about this, to try and figure out if we could see where you were the day you were admitted, what setting you were in. Were you in a long-term care facility? Were you at home? And then we looked forward from the hospital discharge date to look for death, admission to other inpatient facilities, admission to long-term care. And by default, if we couldn't find you in any of these other settings, we thought you were in the community. But again, that's some work that needs a bit of sensitivity analysis. And then we looked at differences between men and women, because I think in this type of population, the gender differences are quite striking. And we also looked to see if people were known to have a usual provider of care. So with primary care services being rostered in the province, it's much easier to link individual patients to their family physicians. So this is the sort of picture of what I just said in words. So if you were an older adult who was discharged alive from ALC stay, we linked you to all these other health administrative databases to get a profile of how you were interacting with the system. And this, again, just shows you those little look-back windows I described in terms of what we were looking at. And so I think the things that we're still working on a little bit are this definition of where you were when you were admitted. And then we picked a very short time window for looking at where you go when you're discharged. And so, in our data, it would probably look like you were in the community, even if a month or so later you wound up in long-term care. And so I think we could look at some interesting patterns there in terms of if we change that time horizons. So we really wanted to look at how many care transitions there were prior to and after hospitalization. And we were looking at where this work is going is maybe even starting to layer on some information related to functional, cognitive, and clinical levels at each transition point as well. I'll just to stop those of you in the audience who are going to jump up with hands, that there are limitations and challenges to doing administrative research, so we have very limited ability to make causal statements. We're using data that were not collected for research purposes, but are really useful in terms of the population-based perspective they provide on the system. There are ongoing issues with the timeliness of administrative data, so often at ISIS we don't get hospital data until a year after it takes a year to get it cleaned and come to us. And then we have limited information for these kinds of populations on informal support, out-of-pocket costs, and who is accountable for the patient at each time point. We just know who they've contacted. But I do think that there are opportunities in terms of the kinds of data that are now increasingly available across populations, and I point to the RAI data tools and our ability to replicate analyses over time and across regions. So if we looked at this cohort of ALC patients that we constructed, you can see overall, we've got them displayed overall, and then just profiling the men and the women separately. So 60% of the cohort are women and older women at that. If you look at the income distribution, so this is based on census data, based on where people live. And if income was evenly distributed across this population, all of these columns would be 2020, 2020. So you can see that it's lower. Individuals who are ALC tend to be lower income, just slightly, but there is a bit of a gradient. And as well, there are no differences across men and women in terms of whether the populations were rural or urban. If we looked at where people came from prior to being ALC, and again, this is using this very narrow little time window of a day, it looked like 25% of our cohort came from long-term care, and another 60, close to 70% were in the community, and just 3% had come from other institutions. Almost all were urgent admissions, and many, these are just mean lengths of stay, and we've broken that out into the component of their stay that was ALC, the component that was not ALC in the total, and the huge standard deviations, those are mostly driven by the individuals waiting for long-term care home placement. We looked at the most responsible diagnosis for the hospital stay. So people would have had a number of other diagnoses associated. These are complex individuals, but this was just what kept them in hospital for longest, the MRD. And you can see that a lot of these folks had falls and fractures, or the most common cause of being in hospital was falls and fractures, dementia or delirium, stroke, and then congestive heart failure. Falls and fractures, there was quite a big difference between men and women, but otherwise no significant sex differences. when we looked at how often people had contacted the system prior to becoming ALC, over 60% of people had an emergency department visit in the year prior. So these are not people that are unknown to the system. And in fact, close to 40% had 2 or more emergency department visits in the year. We tried to do a little bit of descriptive work on what the nature of those emergency department visits might have been for. And so low acuity visits are things that have the potential to be managed in the primary care setting. And fall related, obviously, there's a slight bump for older women. We did do, for those of you who are a little more technical, we didn't want the emergency, to get into hospital to be ALC, you might have come through the emergency department. And so we actually had a little washout period right around your hospital admission date because we didn't want to capture the emergency department visit that was tied to your ALC episode. We wanted to look for other emergency department visits. You can see again that over 40% of individuals had an acute care visit in the prior year. In terms of physician visits, over 90%, so all of these people had visited a family physician or a primary care provider in the year, almost all, in the year prior to admission. And again, we did a little bit of a washout around the time period of hospital admission because we didn't want to catch a physician visit that was part of the causal pathway into hospital. We were looking for visits prior to that. Many had seen specialists, and each of these we could drill down in a little more detail in terms of how close that visit was to the hospitalization date. And then again, I mentioned earlier that now that many primary care patients are rostered, we can look to see if that individual had a usual provider of primary care, so someone where an intervention could be targeted. And these individuals too, many were already on long-stay home care service. So close to 50% had any type of home care visit in the past year. A lot of those were for case management, but there was also a fair bit of nursing and personal and homemaking support as well. And then this graph will pause. This is sort of a work in progress, and so I'll take a little bit of time to explain it. So this is using that one-day window before you were admitted to hospital, and that's what's displayed on the x-axis or the bottom of the graph. So this is for people who were in long-term care when they were admitted, who looked like they were in an other inpatient setting, who looked like they were in the community with home care or in the community not with home care. And then this looks at where they went when they were discharged from hospital. So it's not controlling for how long they stayed in hospital. You can imagine that some patients or by condition people might be in. But it's just giving a picture of what's happening to people. And so you can see most of these bars, no matter where you came from, the pattern is fairly similar across settings of origin. So most people seem to be, and that's one thing we need to look at in a little bit more detail, seem to be getting discharged to rehab or complex continuing care. And we need to just double check that in relation to long-term care. But, depending on your setting, 15 to 20% are going right to long-term care homes. And that's, again, within 2 weeks of discharge. But also a number seem to be going to the community with home care or the community without home care. So our next steps at ICES are to drill down into this information a little bit more, see if we can identify some patient clinical characteristics that are associated with some of these patterns, and start to explore some of the settings of origin and discharge, particularly the time windows in a little bit more detail to make sure we're getting that progression through the system and capturing it accurately. And then we can drill down and start to do regional variations in this type of work. There may be some patterns regionally. And then also start to look at, for the small proportion of people who had limited prior system contact, if we can get a better sense of them. It looks a lot like you saw in the diagnosis data that a lot of the diagnoses were for falls. So things like precipitating events that may or may not be able to be prevented in advance. At ICES more broadly with these research, we're going to continue to focus this kind of study on important subgroups. So we're working on individuals who are medically frail, who are high cost, who are well, because I think older adults make up the majority of older adults. We've got a cohort that we're looking at focused on dementia as well, and continue to map the service use, but also onto complexity measures and risk factors to the extent that we can. and start to examine the overlap in those sorts of things. So if you've got problems with activities of daily living, do you also have multiple clinical measures? And start to improve our measures of transition and continuity of care. So I think, if there is time for discussion at the end, I'd definitely like some feedback from the group here on how we need to think about profiling these kind of cohorts. What kinds of transitions do you think are important for us to capture at a population level? And if there are other important groups we should think about studying, as well as if there's additional data that you would find useful as you think about these kinds of statistics. So I'd just like to thank Peter Biasucci for starting the research question, and Deborah Sattler, who we've been working with at the Ministry of Health. This is part of a series of projects we've been working on with their groups, and I guess that's it.
I'm sure we won't. Let's save that for the discussion. Well, thanks everyone for joining us. I'm Matt Snyder, the project lead for behavioral support. I'm joined by Mary Ellen Parker. She's from the Alzheimer's Society of Chatham-Kent, and Christine Romanek. Now, the three of us are going to tell you about the Behavioral Supports Ontario project, some outcomes that we've observed. First, though, I'm going to bring that presentation up on the screen. There it is right there. That looks familiar. I'll handle the first, but what I wanted to do was take a closer look at what the project looks like actually at the clinical front line. That's where Mary Ellen and Christine are best able to address the group. And then after we've looked right up close at the micro level and at some data that they've collected in Erie St. Clair LHIN, I'll kind of zoom us back out up to the provincial level, because I've got some data that I've compiled from other LHINs, including some of the LHINs that were mentioned earlier. I think we will see some linkages emerge with the two presentations that preceded ours. So this is a slide I'm sure that many folks here are familiar with. I've presented on this extensively, and others involved with the project have talked about our model. For the small number of people in the room who've never seen this before, let me quickly say that there was a previous phase of behavioral supports that was consultative. That conversation identified a target population that you see here in the middle. So that's older Ontarians with challenging behaviors and their caregivers. That consultative phase produced a report called Behaviors Have Meaning. And the report described a future state system that had been redefined on three basic principles. We call them pillars. They're shown here. They're the pointy bits on this diagram. The first pillar that someone's care should be coordinated. The second, that care within any individual's circle of care should be integrated and interdisciplinary. So within, for example, any care team, you would have specialties and specialized resources available as that client's needs evolved. The third principle, the third pillar of a knowledgeable care team, this is the idea that within any care team, we're constantly learning. We're constantly building up the ability of that team around the client to better manage the client's needs. Now, as I say, this was the vision. We shared that with the ministry, and they were excited about the model that we presented. And we're now into a second phase, an implementation phase. We have $44 million in annual funding from the ministry that supports new health professionals throughout the system. It supports a time-limited service redesign phase. And we're now just concluding that project phase and kind of moving into a next phase where the centralized infrastructure gives way to locally organized efforts. Now this is a confusing diagram. There's a lot of information here, a lot of things you could take away. Let me focus your attention on a few. Take a look at these groupings up here at the top. There were 4 LHINs that went first, attempting to adapt the model to their local service mix for people with responsive behaviors. Those 4 that went first were then paired with 2 or 3 other LHINs in a buddy grouping. And that implementation model, we found, was enormously powerful, especially at the start of the project. What it meant was BSO became a single experiment in 14 laboratories. As we learned in one LHIN, those lessons were moved across the province. And similarly, within any one LHIN, as we learned a lesson in a care setting, it was possible then to mimic these relationships at the local level. And again, begin to translate what works here to what ought to work everywhere. We've had great success with that. And we're hoping that, as the project phase concludes, that's one of the lasting legacies of this project, that we will see good ideas continuing to move using the BSO infrastructure, and who knows, maybe we'll see similar infrastructure developed for other complex and for other client or for other subpopulations. I also want to draw your attention to Health Quality Ontario, the Alzheimer Knowledge Exchange. These are 2 funded partners of the program. They delivered a cornucopia of services that made the project possible. Health Quality Ontario, their principal contribution was to introduce this notion of continuous quality improvement. What they've done is put the skills of quality improvement science into the hands of frontline people and into the hands of system folks, so that BSO is an exercise that's kind of always ongoing. You're always re-examining your service mix. You're always re-examining how you do what you do in order that you can adapt and better meet the needs of the target population. Alzheimer's Society, through its Alzheimer Knowledge Exchange, provides the collaboration infrastructure that makes the project possible. I'll draw your attention to a 4th thing here, the Provincial Resource Team, about halfway up on the right side. This is an expert advisory panel. They're able to confront and comment on challenges as they arise in any one LHIN or anywhere in the project. And then they're also able to give us strategic guidance, sort of chart out a future path for us. That panel meets twice weekly. It's an amazing volunteer effort. It's remarkable that we've found administrative and clinical leaders who are willing to put that kind of extra time as volunteers into our project. Having described for you the model, let me now tell you a little bit about how measurement works within our project. So BSO includes a formal evaluation. That's actually the Hay Group healthcare consultants have been retained to use principally administrative data to try and find the impacts of dozens or hundreds of BSO interventions that are throughout the system. Now, I'm not going to talk about the formal evaluation today. Also, on the subject of measurement, my office, the project management office, the province-wide project management office, collects a wealth of process data about what's being delivered and how. That's another important data source, sort of a real-time glimpse of the performance improvement process as it's underway. And then a third source here, or a third example of measurement, is the scholarly paper that's cited at the top. Now this is out for peer review right now. Our conclusions in the paper, Dr. Iris Gutmanis is the principal on this paper. You see them here, that BSO is a catalyst for change, that for patients with complex and chronic needs like the target population that we're talking about, it's really a system of care that's required. There can be no one intervention. It's not enough just to create some new service and then, the problem is solved. We can move on to some new priority that the ministry's assigned to us. It's a much more fundamental transformation that's required. And in the paper, we uncover some evidence that in fact that's what's happening, that a transformation is underway. It hinges on better integration and on enhancing services for this vulnerable population. And it is also very much dependent on that quality improvement culture that we've put into place. Another conclusion that I draw to your attention before we move on is the idea that this approach, so we've targeted people with responsive behaviors or those at risk of the same. But really this approach is replicable across all sectors and in other jurisdictions. Now, here we have a client value statement that belongs to the Erie St. Clair LHIN, and Christine's going to tell us about that in a minute. A little bit more context before we do. So all LHINs went through their own local process to take that framework that I showed you on the second slide and apply it to their local service mix. The lens that they held up to their own system through that process was the client value statement. So this is Erie St. Clair's, and it defines then the specific interventions, the change projects that Erie St. Clair chose to pursue. And I'll turn it over to Christine to tell us some more about that.
Hello. I am a unique individual, and I am worthy of respect, dignity, and quality of care. Wow, that's a powerful statement. So this statement was developed in the Erie St. Clair LHIN in collaboration to reflect that persons with complex and responsive behaviors are accepted as one is. That persons and caregivers, family, and social supports are the driving partners in care decisions. Respect and trust characterizes relationships between staff, clients, and caregivers. It also reflects that the higher level of services, including mine, are the right care at the right time in the right place. And it acknowledges that all behavior has meaning and is communication. So the Erie St. Clair LHIN decided that we were going to do a hands-on approach and involve the Erie St. Clair CCAC through the Behavioral Support Care Coordination Services. And this is where I come into play. So I am employed with the CCAC out of the Windsor branch, and we have a Sarnia and Chatham branch as well. And the program is initiated in the Windsor branch with additional funding that will span out to Sarnia and Chatham in undetermined time. But as the BSO care coordinator, the target population is the ALC client in 3 Windsor Essex hospitals. So I am traveling within Windsor and as far as Leamington. And these are the clients that present with barriers to discharge. I see approximately 3 to 4 people every week with ongoing case management and follow-up every 7 to 10 days until they are discharged from the hospital. The initial assessment upon referral is within 2 to 5 days, and I have caregiver collaboration about every 1 to 2 weeks. Since inception of the program at the CCAC, which is in September of 2012, I have seen approximately 37 people with responsive behaviors, and that's since September. My program involves intensive case management in collaboration with the hospital health teams and community linkages such as the Alzheimer's. We have a system navigator, the BSO long-term care leads, and we also have the geriatric mental health outreach team. And they help to expedite the patient discharge to long-term care community settings, allowing people to live a normalized way of life. I am using, through my intensive case management, I am utilizing assessment tools such as the RIHC, and we have developed a specialized behavioral assessment tool that focuses on frequency and disruption interventions that are successful and are not. And I am painting for the long-term care facilities that the clients and families have chosen a picture, a true picture of what the patient looks like. The specialized behavioral assessment provides focused information to long-term care facilities that the families have applied to. And I've been told we are going to be conducting a survey, so we should have some data for our next round of the a satisfaction survey, but I am told indirectly that it is a wonderful tool that has provided a really good picture of what the patient looks like. I'm staying connected with clients and families from initial referral to hospital discharge as a one-point access through case management and discharge planning, working closely with the hospital team. So the way that we did our BSA referral process was following the Home First strategies. we built it into our existing processes within our Erie St. Clair CCAC. So all of my clients are assessed by the CCAC care coordinator in the hospital initially, and once responsive behaviors are identified, then we have built in a template that the responsive behaviors are inputted into our CRIS database. The referral process comes to me. I pick up that referral. I'm contacting the family, setting up the appointment, and I am their case manager until they are actually discharged from the hospital. So this slide is showing you that we have a collaborative approach with the Alzheimer's SN System Navigator, the Geriatric Mental Health Outreach Team, the long-term care leads. And this is as of December of 2012. Through the CCAC BSO strategies, you'll see ALC, BSO, CCAC, that's my statistics. Through the collaboration, I have been able to discharge 47.8 or 11 out of 23 patients from hospital to long-term care or retirement home in less than 3 months from being hospitalized. Although not all of the phases of implementation and all parties in the program are up and running, as a clinician, I am seeing improvements with transitions and discharge planning for BSO clients through BSO strategies and recommendations, along with care coordination through Alzheimer's Society System Navigator, Geriatric Mental Health, long-term care BSL leads to improve quality of care and quality of life. Barriers to the program process and utilization will become more obvious in time, but it is evident that people are moving more effectively and quickly from hospital to the community setting through BSO care coordination services at the Erie St. Clair CCAC. This is just a little story I want to share with you. This is one of my clients. Carla, she came into the hospital in a very decompensated state. She had been hospitalized in July of 2012, went home, was decompensated, stayed at home until September, came back in because her behaviors were unmanageable by family. While she was in the hospital, she was referred to me around the end of September because her behaviors were unmanageable even with medication regimes. At that point, she was a diabetic. Her diet was very poor. She wasn't eating. Her blood sugars were very unstable. So through dietary recommendations and supportive behavioral modification with the staff and the caregivers, we were able to stabilize Carla so we could have her discharged from the hospital in less than 3 months to move into a retirement home with her husband and live a normalized way of life. So when I did assess her at the 3-month level, she was a totally different person from when I first assessed her. She actually thought her husband was a porn king.
Okay, I'm just going to touch a little bit on the education initiatives that happened in the Erie St. Clair LHIN. As Matt had described with the 3 pillars, the third pillar deals with education and sustainability of education and knowledgeable staff. So in the Erie St. Clair LHIN, part of our plan was to hire a knowledge exchange coach and that funding will be ongoing. That person was responsible for coordinating the training of every level at long-term care facilities over the past year. So looking quickly at the numbers that are on the slide, to date there's 875 people in long-term care facilities in Erie St. Clair that have been trained in 59 sessions. It's probably more because this was written last week and we're doing them almost every day. So we hope to reach 1,000. We also have quite a large number of train the trainers, which means the long-term care facilities themselves, upon with staff turnover and orientation, can now train their own staff in pieces and You First and GPA and so on. So we're quite proud of our education in Erie St. Clair. For sustainability, we will be doing an evaluation of all those who have been trained, sort of an opinion poll to see if they feel that their education has benefited them in the next 6 months. As well, the knowledge exchange coach will be going to each long-term care facility and going over the Betsy tool with them to see where they are with training and what needs to be done in each facility. So, thank you.
So what we begin to see in the project office then is the impact that Mary Ellen talked about, the spread of training and education kind of multiplying, mushrooming across the system, and the impact that Christine was talking about, and the additive effect of dozens of Christines and hundreds of training episodes, or thousands, in fact, training episodes like Mary Ellen has described. And what I want to take the rest of our time to sort of think over or mull over is how those micro-level change projects and the addition of those specific and local services is adding up. And I think that's a picture that becomes more clear. Again, I said I'm not going to talk about the formal evaluation. That's the Hay Group will provide that in the spring this year, and they'll use largely administrative data to tell that story about BSO's impact. What I see, though, is the data that we collect in order to monitor processes. And so here's some of it. What we've got here are this is Waterloo Wellington Lynn. This is one long-term care home. And you can see all the different types of responsive behaviors. They're all heading generally down. A couple to draw your attention to would be, so here's aggressive behaviors, down from 36 to 23%. Here's socially inappropriate, down from, socially inappropriate down from 20 to 4. On the right-hand side, I've got aggregate data from 3 long-term care homes in North Simcoe, Muskoka, and there you see that's worsening behaviors, down from 17 to 11. My colleague Sean Wiley is in the audience from Mississauga Halton Lynn. He has startling graphs that show responsive behaviors, or the incidence of responsive behaviors in, for example, an adult day program, where the variation starts up around 80 episodes per day, and then it drops to 2 or 1. And it's sustained for months and months and months and months. Wherever you look in the project, it is possible to find examples of the client-level impacts and to see clear evidence of a transformational change. I won't flash all the possible examples in front of you, but let's say that, or let's acknowledge, first of all, that there are many factors at play in order to reduce, for example, these specific measures of resident behavior. But you can see the chain of effects that I'm trying to build. So first of all, you have, for example, in the story that Christine told us, better transitions and prompt referral and better skills for managing responsive behaviors in any clinical setting. And then second, you see here evidence of reduced incidence, so lower incidence of responsive behaviors. Maybe you see where I'm going with this. There are, here's a care quality indicator. This is one resident. So this is a very small sample size, I acknowledge freely. But again, it's possible to find countless examples like this. And in fact, I could also have chosen a long-term care, data from a long-term care home in Central East, one of the first into the program, where they've actually measured the change in their medication use, and they say it's been cut in half since BSO was introduced. What's really dramatic about a client care success story like this? Well, first of all, what's really dramatic is the client and the family and the staff in the home, how their experience is transformed by the change that BSO has been able to foster. But as I say, these stories are multiplying everywhere, and I'm sure you could predict this. You could predict that I was going to go here. These separate and local efforts are beginning to add up into change at the system level that, first of all, I mean, this was one of the measures that the ministry identified for us at the outset in our funding letters. They defined this as one of the measures that they wanted BSO to move. And, well, this is Waterloo Wellington data. You can see transfers to emergency department. from long-term care, varying much higher off the scale to the right. And then with the start of the BSO process, moving from a former average of, this is 5 a month, down to 2 a month. And we're seeing that the data is stable there at an average of 2 a month or more. This is where the story, this narrative that I've tried to make, that's where it culminates. The idea that we're having some success reducing these global measures, these finding evidence of the impact and these global measures of system impact. Again, I mentioned this before. There are countless factors that add up to a move towards a true system indicator like this. But we think that BSO is one of the organizing principles that makes it happen, and that's one of the arguments in the paper that I mentioned earlier. So specific and local changes adding up to better client outcomes, then better care at lower cost. We think that BSO is closing in on the project's stated goals. That's all the information that we wanted to present to you today. Thank you for paying attention.
Well, that's terrific, and we're right on time. We've got lots of time for questions or comments. So we're going to ask you to use the mic. I'll carry that around. We are recording the session. I also wanted to remind everyone that all the presentations are going to be available on the OLTCA website for downloading. So questions from the audience? Comments? Well, I know it's a lot of information in a short period of time. I just wanted to... we have a question here?
I can yell. Yeah, I'm a physiologist, so I can yell if you want. I just wondered, in the first couple of presentations, I wondered whether there was any tracking of culture and cultural differences in that stuff.
In sort of within regions, within
looking at transitions and where does, you mentioned things like male, female, and so on, but is there enough data to look at whether different cultures interact through the system differently?
There's limited data on, so you're talking more about ethnicity and things like that in terms of how that works. Yeah. There's very limited information in the administrative data on ethnic origin of individuals as they go through. I know anecdotally different cultures have different approaches for that sort of thing. I think there are some efforts to increase that data a little bit. I think at least at ISIS we have a richer set of data on new immigrants and how their families might move through that we're trying to link with our existing data resource. The challenge, it's a nice mix of things that was presented today, kind of being right at the patient front and then up high in data level. And I think one of the challenges is knowing what kind of messages your data are good for, right? So the kind of high level population-based statistics give you an opportunity to drill down in a little more detail and look at questions like you're interested in. I don't know if anyone else has anything else to add.
Well, certainly for BSO, and again, so my perspective is province-wide, right? I don't know a lot of details about local efforts, but I can talk generally about what's happening across the province. Culture is crucial. In many places, it's determining. And if you put this question in a formal way, I would go and find project leads from each of the 14 LINs, and they can tell you in detail. Well, so the Somali community is enormous in this particular region, or I have a very large Finnish community, or I have unilingual Mandarin speakers, typically over the age of 80. Depending on how they've cut their local population, and where they prioritize their resources. Absolutely, we're seeing local BSO projects tackling this question specifically and then coming up with very local and very specific mitigations, so that, like in the example of unilingual Mandarin speakers came to mind because just some local work that was being done in Scarborough acknowledged the cultural stigma that was attached to mental health issues, and that was like an ironclad barrier to accessing services until way past the point where crisis had begun. So BSO is all about meeting the person and assessing their needs early and matching them with appropriate services on their full dementia journey. Well, that's out the window if the family can't connect with the formal service structure until long after the crisis has overwhelmed them.
I guess it was a simplistic version of the fact that obviously treatment interacts with the people receiving the treatment, and that's via telling. I guess we don't have statistics that really allow us to look at that kind of thing.
A question in the back.
Hi, you asked us earlier about any ideas for future research. I'm a nurse practitioner in long-term care, and I propose that one major issue about numerous unnecessary transfers to hospital and readmissions are related to the lack of good quality and timely discharge transitional information between hospitals and community. And I wonder if we could look at this at a deeper level, and so we can move ahead to have platforms that support those the transitional care.
I think that's
just putting that.
Yeah, no, I think that's a great suggestion. I think one of the challenges as we move forward with looking at this intersectoral research is finding just like as a provider, you want to be able to share that information across providers. So I think it's great to try and think about. Go ahead.
I think you agree, and I think we would all agree that when we get somebody back from hospital, we don't know why they were there. We get a hospital MAR, which is not discharge medication reconciliation, and then we're supposed to manage their difficult behaviors, their chronic diseases, without having any interpretation about that. And it goes the other way. We're sending our residents to hospital with very little information, and we're hearing back from hospital. So it all kind of culminates to, requesting a platform to be able to do transitional care, but we need the research, the backbone to support it. Thanks.
To your question, there is some research done by Chaim Bell, and he's looking at that piece about drug reconciliation. So persons coming from long-term care who end up in hospital who are off their medications, and how often that happens, because there is no good research. We did have a study a few months ago in JAMA about discontinuation of medication for people who've gone through ICU care, but now we're looking at the long-term care population.
Yeah, that's a big issue, and it's certainly a problem that we're definitely seeing across our sector in long-term care homes. And I work in the Mississauga Halton Land, and we've tried to overcome it by instituting a discharge envelope between transitions. Well, paper doesn't work. Somehow the papers don't, and it's not tied to an order or a process. And so that's part of the issue as well.
Great, thank you.
I just wanted to also let you know that one part of our CCAC that we are going to be implementing, we're just doing the algorithm right now, is that when clients are coming from long-term care into hospital and they're transitioning towards ALC, then they're going to be identified in the hospital in our Windsor area, and I would be notified so that I could work with that long-term care facility to see what is the reasoning to the client not being able to go back to that facility. What is it, a lack of education? Is it the responsive behavior? Is it the lack of staffing? Like, what is the reason, or why is there habitual hospitalization, so that we can work within that particular nursing home to decrease the amount of ER visits by the clients for long-term care. So that's going to be coming our way. We're just working on that algorithm right now.
It's similar to our nurse practitioner program, that we are dependent on and wanting to get those phone calls. They're not tied to an order. They're not tied to a process. You're really depending on new staff being trained to do that, or in their busy day remembering to make the call to you or to make the call to us. And so if we can really tighten that up so that we don't see these complex behaviors and many other conditions bouncing back and forth unnecessarily. Thank you.
That's a great deal of effort within the project has gone to address exactly that challenge. Behaviors are the triggers for behaviors are so personal and so complex and so unique. And when we identify one, it is urgent that get reported and that provide the same thing. And in fact, your example of the nurse practitioners, I think other programs, the system's attempting to do this in other ways. It is absolutely a priority for our work.
And not make it fragmented. Let's bring it all together so we're all on that same page.
One other thing I just wanted to comment. I'm sorry.
Go ahead. We have time.
Is that we have 2 BSO leads in our long-term care facilities. It's divided into 2 sections. We have our long-term care facilities in the city and the ones in the county. So we have 2 nursing homes that have the BSO lead. So the way that our process is, I didn't really speak a whole lot on the Alzheimer's Society System Navigator. I work very closely with her. And she is the triage. She triages my referrals. She will allocate to the appropriate community linkages for the caregivers, but she also triages referrals to the geriatric mental health outreach team and the BSO lead team, so that we can try and stop that hospitalization for that client. The whole gist of it is that the long-term care facilities have to exhaust all their avenues before they can actually send the client to the hospital. So they have to be in touch and making that referral to the system navigator of the Alzheimer's Society, have access to the geriatric mental health outreach team, have the BSO lead team go in and provide the support that they need. So these are all programs that some are transitioning. Our county homes right now are just transitioning, but the city homes are full up and working with the BSO lead. And so we're in the process to really up and running full tilt.
And I'm sorry, it's just one last thing around behaviors. If there, many patients that are in hospital that have complex behaviors are very difficult to place in long-term care homes, for instance, and in the community. Anecdotally, due to BSO, we're now seeing that change. We're now, because of having the BSO in each long-term care home and having the education and training, it is making it easier for us to do those placements. So just kudos to everybody who's involved in that project.
I think it's a very timely point of discussion as well, given recent media events and the changes in our clients as providers, how we manage that. And if you look at the thousands of CISs that have been reported to the ministry since July 1 of 2010 on resident abuse, the vast majority of those are resident to resident. So our ability to manage responsive behaviors, aggressive behaviors, is just critical as we move forward. Any other comments? I was just going to ask Dr. Bronskill, you had a slide up around discussion. You went right through it, and you were going to seek some input from the group. Do you want to take an opportunity for that, or are you past that?
I think someone's already jumped in with a suggestion.
Okay, all right, very good.
Research. I think it's really, as all of you on the front line who are moving to make these transitions happen more smoothly and look at things, it's interesting to try and think about how you measure that success at a high level as well, right? Because we don't necessarily have those causal links. When we're looking, when you treat an individual patient, you can see the impact on their family and on their situation. But if we're looking to appraise the system as a whole, who should we be looking at? And I think with our work at ISIS, we're really trying to do this cross-sectoral approach and identify people partway through a condition in the system and follow them for a long period of time. Because I think it's that in and out where the opportunities for discontinuation of medications or problems with care, the lack of continuity is a big issue.
Great. One last opportunity for questions, and then if not, we'll wrap up the session. Yes.
Can I just ask Matt, is there anybody from BSO that sits on any committee in the hospital? I've done a lot of work with BSO and president, and it's done incredible work in such a short period of time. So it's the full circle, and the person that works at the hospital, and goes out to long-term care. So long-term care don't always get the brunt of everything we send back.
services, and when that local conversation happened within your LIN, if they didn't prioritize good exchange between long-term care and hospital, then that wasn't built up as a result of BSO. So there are LINs where they're leading on exactly that relationship, where they've got that relationship down on responsive behaviors. There are other LINs that haven't focused their energy there, and it sounds like you're in one of those where that it's more the case of the latter. Or you haven't seen it yet, right? Like this is the other defining characteristic of BSO. I mean, this is a journey, right? I mentioned during my remarks the project phase is ending, but maybe I should have been more explicit about that. BSO is now becoming a part of ordinary business for everybody across the system. So this idea that there's a ramp up and okay, BSO is on, okay, everybody pay attention. So that's what's ending. It's the gradual spread and the more thoroughly integrating into the day-to-day business of everyone in the system. That's what's next.
And I just want to clarify that in the hospital, we don't have access to the geriatric mental health. They are in the community and in long-term care. But the fortunate thing is, though, is I do have access to them for collaboration and for ideas and also for case conferences. But in the hospital sector itself, I have provided my own education to the hospitals as far as Lunch and Learns, as to the BSO project, my role as the care coordinator, and so the hospital social workers are all on board, and they're the discharge planners. So they're the ones that are doing the referral to our care coordinators through CCAC. They work collaboratively, and then I work with them collaboratively. So it's working well, and it's moving forward.
Yes.
Very quick question. In Erie St. Clair, did BSO allocate specific staff for everyone?
Yes, I'm looking to my colleagues from Erie St. Clair. It happens that I know this answer. Everybody made their own model. In Erie St. Clair, their model is kind of a mix of the two basic kinds that we saw in other things. So most of the resources got concentrated in lead homes who deliver services out to in a set of relationships with other homes, and every home got a portion of an FTE that is local and anchored in that facility, and that's where the concentration.
So specific champions sort of in that specific home.
Yes, but it's other LINs have more thoroughly adopted that champions model, and that's not Erie St. Clair. Other LINs have more thoroughly adopted the concentrated kind of network out model, and that's not Erie St. Clair.
Great. Well, I want to thank all of you as our audience for participating in this session. Thank you for your comments and questions, and please join me in thanking all of our presenters this afternoon. Thank you.